Hello and welcome to Articulate Community and Family Studies, Equity, Access and Advocacy, Priority Populations within our communities. Before we begin, I would like to acknowledge the traditional owners of Australia and recognise their continuing connection to land, water and culture. I'm currently on the land of the Gadigal people of the Eora Nation and pay my respects to their elders past, present and emerging. I further acknowledge the traditional owners of the country in which you're on and pay respects to their elders past, present and future. As we share our knowledge, teaching, learning and racist practices within the university, may we also pay respect to the knowledge forever embedded within the Australian custodianship of country. This is a very quick outline of what we'll cover in the webinar tonight. I will quickly run through some housekeeping and then we'll hear from our wonderful academics. So there will be a live Q&A session at the end of the presentation. Please feel free to use the Q&A function to submit any questions that you may have throughout. We will try to get through as many as we can. However, please feel free to reach out to our team if there is anything that we do not cover tonight. The webinar will be recorded and will be shared with everyone who has registered, and it will also be added within our learning resources pages where it will be free for everyone to access. We have embedded closed captions for tonight, so please click on the show captions icon to view what we're talking about. And then, as I said, if you have any questions, feel free to email us at fast.partnerships@sydneyedu.au. Tonight's webinar is delivered in partnerships with our academics from the Sydney School of Education and Social Work, as well as the Menzies School of Health Research and the Faculty of Medicine and Health. It couldn't have been possible without all the amazing work that Dr. Kellie Burns, Dr. Grealy, Associate Professor Ilektra Spandagou, and Dr. Cristyn Davies, and the willingness to share their research expertise in equity, access, and advocacy. We're very excited to cover this topic as part of our Articulate Talk series, particularly as it was requested from high schools, and we very much appreciate your contribution and ideas in designing the talk. We hope everyone here finds it helpful for your upcoming assessments. Kellie, over to you.
Hello, everyone. Lovely to be here. I'm joining you from unceded Gundagara country, and I'd like to acknowledge any Aboriginal Torres Strait Islander teachers and students joining us, and to welcome you all here for this exciting webinar that relates to a syllabus that's quite close to my heart, and that's CAFS, as you know. And in particular today, we wanted to focus our talks on the core module, groups in context, because as you're aware, you need to explore 4 specific groups within the community who may be experiencing inequities and examine the nature of the group, their specific needs, and the level of access to services that those groups do or do not have. And in particular, you will be undertaking 2 detailed investigations. And so I hope that in some ways, our little quick chats today provide you with some inspiration or additional information about specific groups in context. And in particular, when you look at groups in context, you'll look at specific groups within the community. You'll be exploring specific groups and the issues of concerns for them, and how do we create positive learning environments. So again, this is taken directly from your CAFS syllabus, but you can see that the focus is on youth, rural and remote families as mandatory groups, and then in the selective groups, we'll be looking today at people with disabilities and LGBTIQA+ community. And this is just showing you the more detailed aspects, which you'll all be familiar with, because I think it's important to always be thinking back to what our syllabus standards are asking us to do and how then we're responding to them when addressing specific topics. So today I want to begin by asking the question, who are we talking about when we talk about youth? And the terms youth and young people are used widely and variously, and definitions also change over time. But according to the Australian Institute of Health and Welfare's most recent data, youth are defined as those people who are 15 to 24 years of age. And there's approximately, in 2023, there were 3.3 million young people living in Australia. And just over half of those were male, and 48% were female. And again, why I want to look at this data is to think about how are meanings constructed around young people? What data or information do we collect and report? And how are the lives of young people understood? So even just with this slide alone, we see that the data around young people is collected in quite binarized ways. So next point, if you could just put all these slides up, that points up, that would be great. So young people represent about 13% of the population, and you can see that the Australian Institute of Health and Welfare provides lots of statistics about how young people live, what types of families or homes, where they are located. And this is to suggest that often our picture of young people is restricted to just these kind of broad brushstrokes or broad trends of who young people are and who they are within our society or communities. But the aim of research, both in health and in education, is to delve a bit deeper, to try to find out young people's experiences and to understand the complexities of youth. So again, I just wanted to give you some sort of idea of how young people are constructed in data and to recognize some of the ways in which health risk is understood. So the latest data from the Australian Institute of Health and Welfare suggests that young people's major health risk factors can be organized first as a major risk is around overweight and obesity. And this is considered a particular risk because healthy body weight is an important factor in young people's current and future health. And young people who are considered overweight or obese are more likely, evidence suggests, to remain obese as adults. And again, there's some patterns here that you can have a look at to show what the trends are around overweightness and obesity. And what we see is that in the older years of youth, so 18 to 24, we see a sort of increased probability of overweightness or obesity. And so it suggests that, you know, there's changes in levels of activity, perhaps changes in the way in which we access our diet, maybe once we leave home and head off to tertiary options or into the workplace. And so these are just some important trends around risk. Another major health risk factor for young people is substance use. And in particular, we in Australia have been tracking smoking data for a very long time. And this is a sort of major health priority area when it comes to young people. And what we can see is that in self-reported data, fewer young people than ever are smoking daily. What a more concerning trend is, though, is that there's a sharp increase in the use of vape or e-cigarettes amongst young people between 2019 and 2022, 2023. And so many of you in your PDHPE subjects prior to CAFS will have hopefully done some focus work around e-cigarettes and some of the risk factors underscoring the use of those. Okay, obviously alcohol and illicit drug use is another area of focus when we're collecting health risk data about young people. And in particular, we can see that 2/3 of people aged 14 to 17 had never had a full serve of alcohol, compared to the 16% in the age group of 18 to 24. And I think why this particular piece of information is interesting is that a lot of young people might assume that everybody actually has had a full serve of alcohol before the age of 17. And so this data is interesting in trying to shift social norms, because we know that social norms are largely determined by assumptions about patterns of behavior. Okay, so what we assume other people doing might drive our behaviors more than what people are, what the trends actually are. You can have a look through these in more detail when Joyce forwards these to you, but I just want to show you some sort of trends and patterns. And this is an area that I'm particularly interested in. That's young people's sexual and reproductive health. So it's listed as a significant health risk area and a site of important intervention for young people. But what we can see in our most recent national surveys, importantly, is that 61% of young people surveyed reported they had sexual experience or were currently sexually active. And you'll see a shift in how we understand sexual activity to include oral, vaginal, and anal sex. So, decades ago, we weren't looking at those things. We had a very narrow understanding of what it meant to be sexually active. And you can see trends on here around condom use, about what young people are talking about together. And I just wanted to point this important one out, which is that where young people are seeking out their information. So we see that websites are very important, but that actually the most significant source of information are friends. And we still see mothers as an important source of information, and GPs, which is a good thing to see. But significantly, teachers aren't listed as a source of significant information, though 96% of students did suggest that they had relationships and sexuality education, or that they felt it was important, and had received it. Okay, but it's whether or not it's relevant is an important question to those of us working in this field, and we're constantly working to increase the effectiveness of school-based sexual health literacies. This slide is to show you that while these trends are one thing, how we think about youth and research practices is changing significantly. So there's a growing recognition that adolescence is a historically varied concept, that how we've understood adolescence has changed significantly over time, and that we're moving to a phase where we have more complex ways of thinking about and understanding young people that centers them in our research processes. You'll see a lot of references to Gen Z and Gen Alpha. And this type of generational research that is often circulated on social media and so on tends to see young people as being a homogeneous group, where you can chart certain trends based on what you access as a generation. And while this can be kind of important in thinking about young people's technology use and the norms in the society you're growing up with, it is also data that has been challenged, or framework that has been challenged, because it tends to generalize. Instead, youth studies that looks at the social determinants that shape young people's experiences and your health and well-being tends to be far more useful in helping to draw out the nuances of individual groups within this big category, youth. And also, research that looks at social determinants recognizes the diversity of young people's experience, but also the ways in which intersectional experiences of geographic locatedness or of race and ethnicity, and how inequities shape our experiences of being young. Okay, and it resists settler colonial perspectives of young people, and tries to ensure that young people, importantly, are at the center of the research process. So there tends to be in research this adult-child binary that takes place, or a big binary between adolescence and childhood, and those are troubled in research because we want to challenge the idea that young people are in transition between childhood, that it's a middle ground, and to recognize instead that young people represent a very important demographic in our society, and that it is a substantial period where health behaviors unfold and where identity is being formed. Okay, so this little infographic you can have a look at, but it shows how reductive this is and how it fails to give agency to young people. It sees you as a homogenous group, which you can just look around you if you're with your peers and recognize that you all live such different lives and you have varied experiences. And finally, just in that idea of thinking about adolescence, when we look at a determinants approach, one of the important things we think about is that as we reach adolescence, what we need from our world around us changes. So for example, teens might need more privacy. So in considering what social determinants impact our well-being and health, living in precarious living conditions at that time represents additional burden or strain. Likewise, as we get older, as we move from childhood into our adolescence, there's a growing need for independence. And part of that is being able to go to school or to work with a greater degree of independence. So having access to safe, efficient, and affordable transport at that point in our life becomes a significant determinant. Other key determinants in adolescence are about access to nutritious food, our neighborhood environment. Do we have support for recreation and physical activity? But of course, also our family unit will have a significant impact on our adolescence, along with our income and employment opportunities in this time. So I'll leave it there. I wish I had more time, but please contact me if you have any follow-up questions. Okay, so it's a pleasure to hand the talk over to my colleague, Associate Professor Ilektra Spandagou.
Thank you, Kelly. So in my short talk, I'm going to talk about disability and equity issues in the era, the current era, and especially the Royal Commission into Violence, Abuse, Neglect, and Exploitation of People with Disability as an example. As a starting point, I want us to think, what do we mean when we talk about people with disability? And I'm going to use the definition from the Convention on the Rights of Persons with Disabilities, the United Nations 2006 Convention. And it puts forward a very new and revolutionary understanding of disability that has developed from the 70s as part of the social model of disability that sees disability not as a static concept, but rather as an evolving one. And it results from the interaction between persons with impairment and attitudinal and environmental barriers. And it is this interaction, it's that contextual constructions of disability that hinders the persons with impairments full participation and effective participation in society on an equal basis with others. So I'm going to give you an example of how that works in practice. What do we mean about the social construction of disability? So for example, I have a vision impairment that you can see, like it's very visible. It's not a hidden disability. You can see my glasses. Maybe some of you are wearing glasses as well, or you have contact lenses. And if you are part of the over 14 million Australians that have that estimated to have one or more chronic long-term eye conditions. So this is a vision impairment. But the reality is, because of how our environmental conditions and our attitudinal conditions are framed, the large majority of this group of people in Australia, they don't define themselves as people with disabilities. And the reason is because the majority of people that they have a vision impairment, they don't experience ongoing environmental and attitudinal barriers. So they don't experience disablism. They rather experience a relative access to optometrists, to the tools they need for rectifying the vision and functioning without restrictions, and attitudes that say that what they experience is not disablement, but rather a condition that many share. So this is an example of how disability is constructed, because within this group, this large group of people, there are people that they experience disablement, and they define the visual impairment as a disability. The other thing that I said before was that disability is not static. And if you see the graph, you see how it changes over time. So disability is part of the human condition. And as we go through our life, the extent that we have or not a disability will be different. Now, there are some variations, and as I said, disability is an umbrella term that covers the complex relationship between a person with impairment and the environment, but not all impairments as normative as visual impairments. So there are the impairments that the diagnostic criteria or the way that they understood, it's much more contested. And we have a lot of conversations about what is an impairment, what is a condition, and how we diagnose, and what does it mean. So often in our conversations, we use impairment and disability interchangeably, and that creates some confusion. But some of the other terms that I will use is disablism, which refers to structures and processes in society that oppress people with disabilities. And it is disablism, and it's a complementary concept of ableism that create these attitudinal barriers and processes that people with disabilities experience. So ableism refers to perceptions that people with disability are inferior, and amongst other forms, it can be expressed as hatred and disgust. And it can be, it's big part of what we call attitudinal barriers. A lot of this is expressed through language, which is a very powerful conduit for expressing our attitude. So we use many words to talk about disability, and a lot of this language reinforces stereotypes. So we talk about sufferer, victim, wheelchair bound. So these are words that they carry ableism. They carry a particular way of being, live, and think as seen as inferior. We also use disability-related words or impairment-related words with negative connotations, but not necessarily towards people with disabilities, but as part of our general discussions to general population. So someone might say, oh, I'm such an idiot, for example. But this apparent use of language might seem innocent because it's directed to ourselves, but actually is disabling. It carries again ableism in the connotations that it makes. There are different ways of talking about disability, and you might have noticed that I use person-first language, so I talk about people with disabilities. And I'm doing that because this is the language used in the Australian policy and also in the Convention on the Rights of People with Disabilities. However, there are other ways, and they're very powerful ways. For example, identity-first language, which is used in many contexts, emphasizes that the disability is not simply part of a person's identity, but rather it is the person's identity. So it's not simply a person who has autism as an appendix, but autism is the person. So that's why a preference for autistic person rather than a person with autism. This is a very big conversation and way beyond what I can convey in the time I have. But it is something that you need to think about in your own decisions around language, both if they relate to your own lived experience, but also when you talk to others. And who is that you're taking your cues about what language to use. So definitions matter because they tell us who is counted in, and definitions put parameters around what we look as disability. So for example, the CRPD, the Convention on the Rights of Persons with Disabilities, refers to those who have long-term physical, mental, intellectual, sensory impairments, which in interaction with various barriers may hinder their full and effective participation in society on an equal basis with others. A different definition we use is the Australian Bureau of Statistics in the Survey of Disability, Aging and Carers. And in this case, it's any limitation, restriction, or impairment, so it's a little bit more broader, which restricts everyday activities and has lasted or is likely to last for at least 6 months. So it has a time frame. And according to this definition, we estimate that approximately 5.5 million Australians, or 1 in 5, based on this definition, has a disability. And this number has been increasing. It's related also to age, as I said. So the older we are, the more likely for having, for being identified as having a disability. So we define what is a disability, and we have official definitions. We also count how many people have a disabilities, but also we use parameters, like defining parameters to provide resources. So here in this slide, I have some of the eligibility criteria for the National Disability Insurance Scheme. And you probably, as you are interested in that area, you're hearing about the review of the NDIS and how changes will come, which might have a huge impact on how resources and supports are provided. But the general parameters there to define who is going to be counted is relates to age. So it's available to people between the age of 9 and 65. The other supports earlier, like early intervention supports, or later, like pension-related supports. But this is the age that the NDIS covers. And so on. So I'm not going to go through all of that. Okay, and this is an example for education. And as I will move to the next slide, I want to say that, again, who is covered and why is defined by the parameters of the system. And this is the National Consistent Collection of Data. So coming to the Royal Commission, it lasted for 4 years. And what it did was it told us how much of varied experiences of violence, abuse, and neglect people with disabilities experience. So a lot of the submissions come in different formats. This is a submission that it is a creative submission by Monique Crowden, which is a disability advocate, and it tells what Monique thinks about inclusion and particular education. But there is a lot of different opinions about what is good provision for people with disabilities, and not always comes from people with disabilities. I don't have the time to talk about the recommendations of the different commissioners, but there was a big split in education, for example. And this is an example where decisions about what is good for people with disabilities made by people that not necessarily are people with disabilities. I'm finished here, but when we look at the needs of people with disabilities, we need to look at who is counted and who has a voice to make decisions about the supports available to them. Thank you. I think I have some references, and then we're moving to the third presentation by Dr. Liam Grealy. Thank you.
Thank you, Ilektra. Good evening, everyone. Thank you to Kellie for the invitation. So my name's Liam Grealy. I work at Menzies School of Health Research, and I live in Darwin. Darwin is on Larrakia country, and I acknowledge past and present Larrakia elders whose country was never ceded. So I'm a housing and infrastructure policy researcher. I might also sometimes say that I'm a policy ethnographer. This means that I don't only think about policy as texts that might be revised or rejected. Rather, I'm interested in what anthropologist Tess Lee might refer to as policy ecologies, or the worlds in which policy is produced and how they're related to the terrains of policy implementation. So that means that as an ethnographer of remote housing policy, my field sites range from the offices of public servants and Aboriginal community controlled organisations to trailing maintenance officers while they go about their work, to the houses where residents live with broken things. So what does this work mean in practice? Last year, I finished a 2-year monitoring and evaluation project focused on Healthy Homes, which is the Northern Territory Government's remote community housing maintenance program. I'm currently working on 2 main projects. The first is an evaluation of the Homelands Housing and Infrastructure Program, which is based on $100 million of Commonwealth government funding for upgrades at Northern Territory Homelands. The second is a project for the Peak Body Aboriginal Housing NT, and it's focused on developing options for an Aboriginal governance agency that might facilitate a transition from the current public housing model in the Northern Territory to an Aboriginal controlled remote housing system. So this is a short talk, so less is more. I'm just going to make a couple of points about dominant ideas related to house breakdown in remote First Nations communities. And I'll do so by promoting the work of Health Habitat, which is a not-for-profit company that I've worked with quite a bit over the years. So in March 2018, the Northern Territory government was criticised for tin shed extensions built in the remote community of Ali Kurrung, which is sort of just south of Tennant Creek and a few hours north of Alice Springs. Aimed at easing the pressure of crowding, reducing wear and tear, and residential flexibility, these room to breathe program extensions resembled 1970s town camp huts more than contemporary housing. Residents expressed concerns over structural defects, and the contractor was tasked by the department with reworking the structures as outdoor living areas. So failures in design, consultation, construction, and auditing produced corrugated iron sheds that were almost housing. The review of the then recently completed National Partnership Agreement on Remote Indigenous Housing commended that agreement's success in expanding total housing stock or supply and reducing crowding. Alongside new builds, the review emphasised the importance of maintaining existing stock through planned repairs and maintenance. While the NT government's remote housing funding package has allocated $200 million to preventive repairs and maintenance across the decade 2018 to 2027, there's thus far not been a significant shift by government towards the prioritisation of repairs and maintenance. We can think about the prioritisation of new builds and major refurbishments of new construction over the importance of repairs and maintenance as part of what I call a sector-wide assembly fetish, by which I mean a couple of things. So first, the new house offers the potential of radical transformation. It evidences a house building capacity, and new houses promise to magically solve wicked problems cast as masthead policy goals. So to close the gap on Indigenous disadvantage. The new house represents policy success, and that is ritualised in a handover of keys or in a ribbon cutting. Second, the political economy of the assembly fetish situates profit-making opportunities at the capital work stage rather than in ongoing repairs. You make money at the front end. So construction signals the conclusion of serious government funding and scrutiny, from which point superintendents shifts to tenants. So taken together, the assembly fetish displaces consideration for the ongoing requirements to hold things together. Construction cycles orient us instead to the next new build as the work that really matters. So returning to Ali Kurrung, the thing that is more cage-like than outdoor living area provides a limit for what might masquerade as housing. Resident and ally critiques of non-housing, in this instance, produced government remediation. But this example is, of course, atypical. Most new housing resembles a common sense architectural aesthetic and is recognised as housing through project manager approvals, contract acquittals, and other sorts of statistical abstraction. The temporal lag between a ribbon cutting and visible construction defects shifts culpability onto tenants who, in conditions of scarcity, i.e. housing shortage, have to endure those broken things. So the assembly fetish thus relies on a pragmatist conception of housing. We take that idea from William James, who is also important for some of those ideas around adolescence that Kellie was talking to. And that is, if it looks like a house, people live in it and they're governed as tenants, then it's housing stock. So survey fix 1 on this slide is the 4th stage of any Housing for Health project outlined there. The slides will be shared later on. In Survey Fix 1, 250 household items are surveyed, with many fixed on the spot, according to ophthalmologist Fred Hollow's motto of no survey without service. Data is collated to generate work orders for licensed tradespeople who follow the Survey Fix teams in a Housing for Health project through houses in subsequent days. In the mid-1980s, the head of the health service on the APY lands of South Australia, Yami Lester, pulled together a team to address the poor health outcomes of local Indigenous people. Later formalised as Health Habitat, they developed the Housing for Health methodology as a repairs and maintenance approach based on the role of domestic, what they call health hardware, taps, tubs, sockets, cupboards, based on the role of that health hardware in enabling residents to enact these key healthy living practices. Sorry, I've lost the slide. But those key healthy living practices are what you need as a householder to maintain good health, and they're all the basic things we would expect of our homes. First, that they're safe. Second, that you can safely prepare and cook food, dispel wastewater, wash yourselves and your kids, wash your laundry. Those key things for which there's a strong correlation between their absence and poor health outcomes. So applied in over 10,000 houses across Australia and elsewhere, and proven to reduce hospital separations for residents, Housing for Health's major discursive contribution has been to evidence why health hardware fails. Those are those HLPs. So the reasons why health hardware fails are chiefly poor original construction and a lack of repairs and maintenance. So contrary to the assembly fetish, Housing for Health as a program demands a functionalist conception of housing. It might look like a house and it might provide a home to rent-paying tenants, but if you can't wash your kids, clean your laundry, dispose of wastewater, then that's not a house. So by intent and design, Housing for Health, the methodology circumscribes its intervention. The chief technology is the survey, 19 sheets that focus on subcategories such as lights, shower, laundry. Each sheet lists items to test, fix where possible, and record the results. Team members usually work in pairs, dividing labour according to confidence and preference, and developing a familiarity and rhythm as they move through houses in a community. The survey pulls certain features of the domestic environment into focus while others recede. So when you're doing it, it identifies where you should be, what you're testing, how, and to what standards. In that sense, the contents of the fridge is irrelevant to whether it passes a temperature threshold. The bathroom's cleanliness does not indicate its capacity to heat, distribute, and drain away wastewater. Similarly, a manicured lawn and a mop floor anticipating the arrival of the Housing for Health survey team do not correlate to functional health hardware. From a different angle, a housing department inspection focused on cursory visual assessments, tenant interrogation, and ensuring an asset's exchange value is useful for constituting pragmatist but not functionalist housing. What matters in the Housing for Health methodology is what health hardware works and what doesn't, determined by testing, what can be fixed as you go, and what requires further attention from tradespeople. So just to finish up, I'm forever banging on about the importance of establishing properly funded, planned and cyclical maintenance programs for remote housing. Instead, in responses to infrastructural breakdown, and especially in remote Indigenous Australia, it's the one-off, the stopgap, the pilot, or the band-aid intervention that's the norm. So sporadic attention in Indigenous policy operates through repeat tenders billed as innovation, with an emphasis on novel, visible outcomes, this assembly fetish. Innovation in this space will not come about through 3D printing or AI or any other techno fix. Instead, innovation would be to sustain attention to housing breakdown via the expansion and routinization of a proven program through systematic funding for its repetition. Thank you. And it's my pleasure to hand over to my colleague, Dr. Cristyn Davies.
Thanks so much, Liam. It's a pleasure to be here talking to you all this evening, and thanks so much to Kellie for the invitation to participate. My name's Dr. Cristyn Davies. I'm a Senior Research Fellow in the Specialty of Child and Adolescent Health in the Faculty of Medicine and Health at the University of Sydney Children's Hospital Westmead Clinical School. And I'm also President of the Australian Association for Adolescent Health, which is actually free to young people under 26. So please join, we'd be delighted to have you. So what is health advocacy and what is the role of a health advocate? Advocacy for health equity is a deliberate attempt to influence decision makers and other stakeholders to support or implement policies and practices that contribute to improving health equity using evidence. Advocacy should also support people with lived experience of health inequity to speak and self-advocate as appropriate. So I do a lot of work with young people with lived experience of various different health conditions to advocate for themselves. And that's often what we do through the Faculty of Medicine and Health, and also through the Australian Association for Adolescent Health. In public health, advocacy can be used to overcome major structural, and that's as opposed to individual barriers to public health goals. So for example, if we have inadequate data collection for lesbian, gay, bisexual, transgender, queer or questioning people to inform health interventions, then it's really difficult for us to understand where our resources should go in order to help these communities. There also might be long wait lists to access publicly funded healthcare. So the role of health professionals as advocates is to determine and understand the needs, speak on behalf of others when required, and support the mobilisation of resources to effect change. So we know that young people are really, really amazing, incredible advocates, and that young people have been absolutely pivotal to advocacy in the area of climate change. We've got lots of young people here too. So we've got Chanel Contos up there, who has advocated for sexual consent education. We've got other young people arguing for system change to address climate change. Georgie Stone, who's done incredible advocacy for transgender young people. Grace Tame, who's done incredible advocacy and was former Australian of the Year, and particularly addressed the needs of young people who have experienced sexual abuse. Brittany Higgins has and Saxon Mullins have both advocated for changing in sexual consent laws. And Duan, who's in an incredible documentary called In My Blood It Runs, has advocated to change the criminal age of responsibility, which has been 10, and there are lots of arguments to raise that to 14, which is still incredibly young, but certainly better than 10. So what strategies can you use to advocate for improved health equity? Advocacy strategies may include using high quality research. So all of us this evening who are chatting with you are involved in high quality research, and we can collect evidence in order to try and make an argument to improve health equity. We can also highlight individual stories with compassion. So while numbers are really important and statistics are really important, it's really the individual stories and the narratives that we tell that really generally make an impact with the general public. It's also really important to build relationships with, for example, members of the medical community, which is something I do and something I encourage young people to do. It's really important to build a coalition with like-minded organisations, to lobby governments and politicians, and to engage in media to promote your key messages. So lots of young people now are using social media in order to get across their key messages in advocacy. Successful strategies should establish your aims and objectives, frame the issue. So, for example, changing policies and practices, or arguing for more funding and advocating for solutions. And your strategy may include vision, aims and arguments, exploring the problem and potential solutions, devising a timeline and action plan, and building your networks with key players in particular. Also implementing an action plan, and really importantly, evaluating your efforts as well, because if you don't evaluate what you've done, then it's difficult to understand whether or not it's been successful. And I've got a bit of a infographic there for you. So I'll just give you a bit of an example. I was funded by the Department of Foreign Affairs and Trade a few years back in order to advocate for issues that were important to me. So my goals were to extend my knowledge, understanding, expertise and networks within an international context. And I wanted to positively impact the health and well-being of LGBTQ+ people with a particular focus on young people. And some of my other goals were to gain in-depth knowledge and understanding of the United Nations Human Rights Council and international advocacy. I also wanted to work towards the elimination of cervical cancer and other human papillomavirus-related diseases in Australia and globally through timely gender-neutral vaccination. And gender neutral basically means in Australia, we vaccinate all young people who are eligible with HPV vaccination. That's what they're offered. And I also wanted to work to enable equitable vaccination across Australia to lower and middle income countries using both standard and also innovative vaccine delivery systems. But for the rest of the talk, I'll be talking about LGBTQ people and the advocacy I've done in that area. So what is the United Nations Human Rights Council? It's an intergovernmental body within the United Nations system. It's comprised of 47 member states. And when I spoke at the UN, Australia was a member state. We're no longer one at the moment. It meets at least 3 times per year in Geneva and Switzerland. And it's mandated to strengthen the global promotion and protection of human rights and also to address human rights violations and situations of concern. It's also a subsidiary body of the United Nations General Assembly. So it was important to me to advocate for improved data collection of LGBTQ+ people, and because this promotes a public health and human rights approach. And it contributed to the development of a toolkit. This is my advocacy, known as the 2020 standard. And if you Google this, you can find this standard, which is on the right. So the standard for sex, gender variations of sex characteristics and sexual orientation variables. And this tool was developed by the Australian Bureau of Statistics to standardise the information collected. The tool was developed in consultation with LGBTIQ+ communities, and it's considered best practice. Currently, we don't understand how many people identify as LGBTIQ+, where they live, or important information about their health and well-being. And this is a serious concern. You might have heard some advocacy at the moment to also include these questions in the 2026 census. So another example is a study I was involved in called Game to Play, exploring the experiences and attitudes towards sport, exercise and physical activity among same-sex attracted young people. And here there's a bit of a list here about some of the requests that young people would prefer. And some of these things include for organisations to provide non-binary options on sporting and leisure, organisation and registration forms. Also, young people requested mixed teams that are grouped on different categories such as ability rather than sex and gender. And here's my name. I'd be delighted to have further contact with you, but I'm going to hand over to my colleague Joyce for the Q&A. Thank you.
Excellent. Thank you so much for your presentations, everyone. We greatly appreciate it. For anyone participating, please feel free to type your questions into the Q&A and we'll answer them very, very shortly. Just to kind of get started, and this is open to all presenters, students often ask, when can they find more resources relating to these topics?
Certainly the Australian Institute of Health and Welfare has a range of documents, and I really like using our major resources or reports, and then having a look at where they've drawn their information or data from. So often they'll make reference to other reports. And of course, if you want specific information about any of our talks today, you can also have a look at our university profiles, which are public, and provide you with some examples of publications that we have in these areas. Does anybody else want to make some suggestions?
Just quickly, so the organisation Health Habitat that I spoke about, they have a website that used to be called Housing for Health, the Guide. It's now just called the Guide, and that's also includes a lot of information both about their program, but what they've produced over the last couple of decades, which is a National Indigenous Housing Guide, which essentially has detail around standards for building in remote contexts that exceed the National Construction Code and related codes.
Perfect. Thank you so much. While we give everyone a chance to type the question in, I'll just ask you very quickly to go around and just give a little bit more of an overview about what you're teaching and also or what you're researching here at the university.
Thanks, Joyce. I work in the School of Education and Social Work, and I contribute to primarily the health education curriculum unit. So I teach incoming pre-service teachers or initial teacher education students their health education. I teach stuff around the social determinants of health, and I also teach elective units about sexual health and understandings of and practices for young people's sexual health.
Excellent. Thank you. Ilektra?
I'm in the same school with Kellie, so I'm in Sydney School of Education and Social Work, and I teach if not all, in most of the programs we have, because all of the pre-service programs we have, they have a component around how to respond to diversity in classroom, and especially to disability. And so I teach pre-service teachers. I teach at the Master of Education, and also have the pleasure to supervise honor students and PhD students and work with them in their projects.
Perfect. Thank you so much. Liam?
I don't teach. I haven't taught for a long time. When I used to teach, it was in the Department of Gender and Cultural Studies at the University of Sydney, and I taught units on youth and youth cultures, masculinity, cultural theory, but it's been a little while.
Excellent. Thank you. And Cristyn?
And I teach in the specialty of child and adolescent health. So I teach people that are learning to be doctors, and I also teach in the Master of Pediatrics. So that's people that are learning to be pediatricians who might be focusing on child and adolescent health. And I also teach in the Masters of Sexual Health. But excitingly, I do a lot of collaborative work with Kellie Burns. So we love to bring health and education together to do some really exciting work around vaccination for young people, health literacy. And I also do a lot of work in the LGBTQ space. So really super busy and do lots of research across the faculty. So thank you.
Yeah, perfect. Thank you so much for that. I'll just move on out of interest of time. But again, if you have any questions, please type them in and we'll go through them. To stay up with any upcoming opportunities and events, you can also sign up to our Faculty of Arts and Social Sciences Participate High School newsletter as well. And also I know that a lot of HSC students are also starting to really go back to revision for the HSC exam. So please feel free to scan the QR code here, and it will take you back to any previous articulate recordings, particularly across English, Kappa, Here's the Subjects, Languages, PD Health PE, and more. We also have podcasts available. So yeah, feel free to scan the QR code and have a look at those ones as well. And that brings us to the end. Thank you so much for joining, and wish you all the very best with your upcoming assessments. Have a good night ahead.